Thank you for your patience, everyone. We had a little bit of a late start. Congratulations to the Cagdin High School graduates who passed by us in millions of cars. Very exciting day for them. Welcome to this public hearing on the Medical Referral Program. My name is Tina Saban. I am the chair of the Health and Welfare Committee, and I now call this meeting to order. Today is Friday, May 26, 2021, and it is 3:35 p.m. For the record, present today from the committee are Vice Chair Layla Staffler and Representative BJ Assel. We do expect the other members of the committee to be making their way over here shortly. With 3 members present, we have a quorum. Staffing the committee today from the Legislative Bureau are our legislative assistants, Cameron Nicholas and Bono Taitano. Also, John Diaz, who's working IT, and Sergeant at Arms, Dennis Regis. And we also have our legislative aide for the committee, Ms. Nava Koram. With that, colleagues, may I please have a motion to adopt our agenda? Motion has been made and seconded. All in favor of adopting the agenda, please say aye. All opposed, say nay. Motion carries. We'll now move on to the opening statement of the chair. Colleagues, distinguished guests, and members of the public, we are now in our 4th and final public hearing on the Medical Referral Program to review the program and examine how it can be reformed and restructured to improve accountability and services and health outcomes for our people. The purpose of the Medical Referral Program has always been to enable residents to access healthcare that is not available on island. Though the program has existed in one form or another since Trust Territory days, it has also changed hands from the Department of Public Health to CHCC and the Office of the Governor. There still remains no enabling statute that formally establishes the program by law or the parameters for eligibility, coverage, and services. Proposals have been made to transfer the off-island referral program back to CHCC, which currently still manages the inter-island referrals, or to establish a more independent medical referral office in the executive branch. The program has consistently exceeded legislative appropriations in the millions of dollars since at least 2009, but as the medical referral director pointed out last week, appropriations for the program have also consistently fallen far short of budget requests, and funds have been reprogrammed throughout the years to cover these costs. Medical referral has been cited as a major contributor to the Commonwealth's annual deficit in the Secretary of Finance's annual report to the Governor and the Legislature. We have thus far conducted hearings on Rhoda and Tinian, where we heard testimony from the mayors and health center directors on both islands, as well as members of the communities there. We also conducted our 3rd hearing last week here in Saipan in the House Chamber and received testimony from the Director of Medical Referral, the Acting Chair of the Medical Referral Board, and the Commonwealth Healthcare Corporation Special Assistant for Policy, Sustainability, and Development. Today we'll hear from CHCC's Chief Executive Officer, as well as the Department of Finance's acting Secretary, the Special Assistant for Administration, and the CNMI Medicaid Agency Director. We also welcome oral and written testimony from members of the public today. We ask that oral statements be limited to 3 minutes or less. We will allow for extra time, up to 5 minutes upon request. Longer written statements may be submitted today or at a later time to the committee. And now let's begin with the testimonies of our invited witnesses. Sergeant at Arms, if you can please escort our guests. We have Ms. Esther Munya, Ms. Margaret Bertha Torres, Ms. Matilde Rosario, and Ms. Helen Sablon. And if there are no objections, colleagues, we'll go through the oral statements of all of our guests, and then we can begin with question and answer. And why don't we start with our CEO, Ms. Esther Munya. You may proceed.
Thank you. Good afternoon, Honorable Chair and members of this committee. My name is Esther Nezama Munya, and I'm the Chief Executive Officer of the Commonwealth Healthcare Corporation. Last Friday, the CHCC Special Assistant for Policy, Sustainability, and Development shared CHCC's leadership position on a proposed transfer of the program to the CHCC. And that statement was CHE does believe it has something to offer to the enduring challenge of an off-island medical referral, but to accept the financial risk which comes with medical referral would be careless of our other responsibilities. So with that, I want to emphasize that CHCC does acknowledge the stories of what had been shared in the past few weeks. Many of us may have had at least one family member, friend, or colleague, or even ourselves have used the medical referral program. The stories are indeed profound, and wonder if we ever need a specialist, will it be available for us? Will it be available on the island so that our families, our support system can be with us? Years ago, I asked this body during a budget hearing to invest in CHCC. A lawmaker at the time replied and said that this program should be treated differently from the CHCC. Well, what does that mean? We found being treated differently meant that dollars could be invested here continuously goes to providers and hospitals outside the CNMI. We have an off-island care program that continues to be not sustainable. We have breakage in the continuity of care when a patient returns from off-island. We have delayed care because it's not just going off-island that individuals think about when accessing care. It's the fear of finding out and realizing that off-island care is the only answer, and the fear of experiencing what comes after, the loss of job and income, and the loss of family support is too difficult to ignore. So I commend this committee for bringing this issue for discussion. And with ARPA funding, what better time of great hope and opportunity for healthcare in the CNMI, and to no longer do business as usual. We commend you for seeking input from the community and agencies, as it is key to developing a plan to improve a program that's supposed to support the health system, to help support families who need care beyond what the CHCC or any provider in the CNMI can provide. As an example, last week, we shared that the CHCC's investment in oncology services resulted in a remarkable decline in referrals off-island for oncology. From 375 patients to 25 patients using the medical referral program to access off-island oncology care in 2 years. This is huge, and it has been so helpful to so many people, especially the most vulnerable and those that could never have the means to have prolonged off-island care. In addition to an oncologist, we've added a radiologist, an orthopedic surgeon, and an otolaryngologist to our list of medical staff. This progress costs a lot of money because we also have to add nursing, the techs, the administrative support, the equipment, and the consumable items that go with providing that care. So again, our statement is CHCC does believe it has something to offer to the enduring challenge of off-island medical referral, but again, to accept the financial risk which comes with medical referral, be careless of our other responsibilities. So while the CHCC continues to work hard to provide these solutions, it is our fervent hope that the outcome of this hearing is that residents will have an adequately funded, streamlined process for healthcare in the CNMI that is effective, cost-efficient, and of the highest quality. Thank you.
Thank you, CEO Munia. And why don't we move next to Ms. Margaret Bertha-Torres for your testimony.
Good afternoon. My name is Margaret Bertha C. Torres, and I'm the Acting Secretary of Finance. And thank you for inviting me to here today. The Secretary sends his regrets and regards and apologies for not being able to make it, but I brought with me his official statement regarding the medical referral program. As the Acting Secretary, I look forward to listening to how the Department of Finance can assist the committee's work in addressing the persistent issues facing the medical referral program. The medical referral program has been a long-standing issue facing the Commonwealth government, primarily due to the recognition of the true cost of the provisioning these services to the people of the CNMI. These services are essential until the Commonwealth builds the local capacity to treat a range of alignments facing its people. And the medical referral program serves a critical function in protecting the life and well-being of our residents. I may not have all the information the committee may desire on this issue at the moment, but the Department of Finance is willing to assist where it is needed in the process. Thank you.
Thank you, Acting Secretary Torres. And Ms. Rosario, if you can proceed.
Thank you. Thank you, Honorable Chair Sablan and members of this committee. I am Matilda A. Rosario, Special Assistant for Administration, Office of the Governor. Thank you for inviting me to provide testimony as well as to share my comments at this public hearing on the CNMI Medical Referral Program. The CNMI Medical Referral Program has been a lightning rod for debate for decades. The costs associated with subsidizing necessary Ovilan medical care for CNMI residents are considerable. Due to the nature of how hospitals schedule patients for the litany of preliminary tests and follow-up tests through the respective medical procedures, which can often take many weeks and in cases months, the effort to cut costs has been a difficult one. Since the early days of the Commonwealth, the Medical Referral Program was a part of the Department of Public Health. With the passage of Public Law 16-51, the Medical Referral Program became part of the Commonwealth Healthcare Corporation, CHCC. With the financial liability and difficulty managing the program in the early days of the CHCC, it was decided by then the late Governor Enos to transfer the program to the Office of the Governor. It was determined that was physically prudent and more efficient due to CHCC's precarious financial and administrative state at the time. Then Governor Enos issued Executive Order 2013-09 in May of 2013 and transferred responsibility over the Medical Referral Program from CHCC to the Office of the Governor. The administration now believes that the Medical Referral Program would be best administered by the CHCC. The administration believes that CHCC is best positioned to look at the cost relative to the benefits of the program and make referral determinations and decisions related to the expansion of healthcare services to more cost effectively address some of the common medical issues currently accommodated by the program. In other words, if a particular percentage of medical referral patients are the result of the lack of certain full-time specialists at our hospital, then it may be much more cost-effective to employ these specialists rather than send patients off island at far greater cost. We believe that these are decisions that our CHCC are positioned to make. Discussions to that effect have occurred intermittently between the administration and the CHCC about the transfer of the program back to CHCC. The additional liability posed to CHCC with such a transfer does remain a concern that would need to be addressed. That said, Governor Torres and Lieutenant Governor Palacios understand how important the Medical Referral Program is to the community and will continue to manage the program out of necessity for the community. The cost of administering the Medical Referral Program are high, and unfortunately, there is no escaping the very high cost of healthcare. We have tried to reduce wait times between tests and procedures, but there is only so much that we can control with regard to Ovilan hospitals and how they handle patient care. In addition to the medical care our residents receive of Ovilan, there are significant costs borne for housing, transportation, meal assistance, and coordinating staff. The Medical Referral Program is a service our people need, and we will continue to do our best to see medical needs met while trying to manage the cost. We will also continue to discuss with CHCC the transition of the program and solutions to address their concerns related to a transition. Ultimately, a transition of the program to the CHCC would require an amendment to Public Law 16-51 to assign financial responsibility of the program to that organization. Thank you, Madam Chair and members of this committee.
Thank you very much, SAA Rosario. And now, Ms. Helen Sablon from CNMI Medicaid.
Thank you. Good afternoon, Chair and members of Health and Welfare Committee. My name is Helen Sablon, Director for the Commonwealth Medicaid Agency. Thank you for the opportunity to be here and to provide comments on the medical referral program. The Commonwealth Medicaid Agency understands the expenses of the medical referral has increased substantially over the years. The CMA, while currently paying a significant amount of monies for travel expenses to the medical referral for patient travel, first observes that many of the travelers are seeking care for non-U.S. Medicaid providers that the CMA is unable to reimburse, since these healthcare providers are not U.S. certified providers for Medicare or Medicaid programs. Certified providers in the U.S. are required to practice in accordance with the conditions of participation of the Centers for Medicare and Medicaid Services. And as you are aware from experiences of hospital in both Commonwealth, the Northern Mariana Islands, and Guam, the CMS conducts annual site surveys to ensure that healthcare providers practice to standards. If the hospitals are not compliant, the CMS provides a report to the provider and requires that a corrective action plan be prepared and executed. If the medical referral authorizes a referral to providers in countries that do not practice to these standards and are not certified by CMS, then the Commonwealth Medicaid Agency is not permitted to pay for reimbursement of services provided. Second, since the providers do not practice the U.S. standards and do not have to submit their medical claims that all U.S. healthcare providers must do, then there is no required data to support the claim. All providers in the U.S. submit medical claims in a standard form that documents the health condition of the patient, the healthcare services that were provided, laboratory tests that were conducted, drugs given, and the cost for the services. All the providers are required to view any insurer, public such as Medicare, Medicaid, or private, Aetna, Staywell, etc. Using the national standard HIPAA ANSI X.12 standard claim form that document the condition of the patient, the services that were provided, the cost of the services. The data then enables any public or private health insurance program payer to assess the cost of the services and determine whether the procedure was medically necessary. The claims also enable an assessment of value of the services provided. And so third, Medicaid does reimburse airfare only for travel to healthcare providers in the Philippines, Korea, and Taiwan, but CMA will only pay for the cost of airfare for the patient and the escort. However, CMA is unable to pay for lodging and other stay expenses. Further, as noted earlier, the CMA will not pay for medical services for non-CMS certified providers. However, please note the following. The CNMI Medicaid program maintains agreements with providers from the CNMI and Guam Furnishing Services under the plan in order for the CNMI Medicaid to pay for services incurred by the Medicaid beneficiaries. No provider agreement, no payment for services. For providers from Hawaii and U.S. mainland, the CNMI Medicaid program relies on the Medicaid provider agreements in their respective states. The CNMI Medicaid program covers the inter-island referrals using the certified public expenditures through CHCC. In addition, CMA requires providers to submit the Medicaid claims and medical treatment authorization document for medical reimbursement. Without both, the CMA is unable to pay the medical bills, thus resulting in significant burden to our Medicaid beneficiaries and healthcare providers. For individuals that are eligible for Medicare and are also Medicaid eligible, the CMA can and does pay for the following costs: monthly premiums for Part B, Medicare Part B, outpatient services, and then Medicare Part A is covered by the Medicare program. Deductible and co-insurance amount under both Medicare Part A and B. Medicare for Part B premium for dual eligible beneficiaries will reduce the CMS portion of medical bills by 80%. Currently, there are 38 facility providers registered in the CNMI and 71 off-island healthcare providers from Guam, California, Hawaii, and continental US. Finally, Section 4 of the CNMI State Plan under General Program Administration 4.44 Program Prohibition on payments to institutions or entities located outside of the United States states that the state shall not provide any payments for items or services provided under the state plan or under a waiver to any financial institution or entity located outside of the United States. Medicaid reimbursed travel expenses in FY 2020. It shows on Table 1 that we spent $10,849,640 on medical reimbursement, and for Guam, it's $3,026,397 federal share, $142,921 local share, and then the total is $3,169,318. U.S. mainland, $7,680,323 the total, $7,489,988 federal share, $190,334 federal or local share. And the transportation expenses that we pay, medical referral, we reimburse them. For non-US countries, local share is $11,298, federal share $106,465, a total of $117,963. And for Guam providers, $15,161 for local share, federal share $130,050 for a total of $142,211. The data in Table 2, or Hawaii and U.S. mainland, the total expense is $521,158, federal share $469,457, local share $50,701. So the data in Table 2 and summary of travel expenses show that the Medicaid program paid a significant amount of monies for the travel to foreign providers for care that are not CMS approved providers. The Medicaid program has not been informed as to the reasons why the referrals to providers in foreign countries was made. Our recommendation is the following. Refer Medicaid beneficiaries to Guam or any other U.S. provider or currently have approved provider agreements with the CNMI Medicaid program and or to Hawaii or the U.S. mainland who is a Medicaid provider within their respective states to avoid incurring preventable expenses for medical referral program. If there is a special reason why a U.S. provider is unable to provide a medically necessary procedure, then such reasons should be documented and made available for review. Refer non-Medicaid U.S. providers to the CNMI Medicaid program to provide further assistance for provider enrollment and to maximize on Medicaid financing. The CMA will review the application for provider enrollment and requirements and require all providers to provide an electronic medical claim. All providers are able to provide such electronic claims to the medical referral program along with other documents that demonstrate the medical necessity and other documents for follow-up care in the CNMI. All providers that do not provide the electronic claim should not be paid until the claim is submitted. Thank you for the opportunity to provide comments in addressing the medical referral program here in the Commonwealth. Should there be any further questions, please do not hesitate in letting us know.
Thank you very much for your testimony, Director Sablan. And at this time, I'd like to recognize Representative Sheila Babauta, who's joined us. Welcome, Rep. Babauta, and our House Counsel, Joe Tyrons. Thank you, Joe, for being here. Are there questions from the members at this time for any of our panelists? Vice Chair Staffer.
Thank you, Chairwoman, and thank you all for joining us here today on this very important topic. I'm sure that there will be more questions as we go. I guess I keep wondering why, because as Ms. Sablan mentioned, why are services being approved to non-Medicaid approved programs? That's, I guess, the question that keeps coming in my head. I don't know which one of you might be able to answer.
Clarification, Chair?
Yes, what was that?
Is there a representative from the medical referral program present here today?
So those representatives were here last week, as you know. But SA Rosario also manages to some extent, but actually maybe we could have you clarify your role with the medical referral program. And if you're able to answer that question, then we could have you answer that.
Okay, I'm sorry, can you, Representative Stafford, can you repeat the question?
I guess I would like to understand why are there approvals for services to non-approved, non-Medicaid approved providers, I guess? Like, could patients have been seen by approved Medicaid providers instead, you know, ones that are not in the foreign countries?
Okay,
Or let me rephrase. Why do we send patients to the foreign country providers, I think would be.
yeah. That I would refer that to the hospital. We don't do referrals at the governor's office. We only took over to oversee at the time when it was taken out of when the hospital became a corporation, when 16-51 took effect. But anyone that's being referred is decided by the referral committee, comprised of doctors, I guess, and health specialists. So the office of the governor is not involved in the decision as to, where these patients go or why they're being sent to countries that do not accept or clinics.
If I may jump in, sorry to interrupt, because this question actually did come up last week as well. And, and we did have the medical referral director here, and as well as the chair of the acting chair of the board. And my understanding, and the members here could probably chime in as well, is that there are instances when Medicaid is not the preferred payer for off-island U.S. providers, and that if time is of the essence, an appointment is needed urgently, and they're not able to get an appointment timely made with an approved Medicaid provider in a U.S. location, then they will refer these patients off-island in a foreign country. And what has also been claimed, but without the data to really substantiate that, what has also been stated is that sometimes it's cheaper to send patients to foreign countries, and rather than to U.S. providers, even taking into account what Medicaid can reimburse. Colleagues, did you have a similar understanding, and do any of our panelists want to comment on that? Oh, yes, Ms. Munoz.
I'm just going to respond on because I really do want to see if you guys can fix this. So, I was at the time when they started contracting with foreign providers. Actually, I was in that conversation about having foreign providers start providing care, because you're right. It is the assumption is that they're cheaper. But what have we seen in the past, over the years, is that the cost has gotten bigger, and a lot of it is because there's no utilization review. So that's how, again, that's my assumption, and based on me being a witness to so many things. But the other thing too is that I used to be in the Medicaid program as well, working with Ms. Vaughn here, and we did at the time try to include foreign providers to be covered under the Medicaid program. And we attempted to do that. And the response from Region 9, and then by the time when we were preparing for that state plan to be revised, the Region 9 director at the time said, because again, going back to 2011, 2012, that was the time when CHEC was underfunded, left to do whatever they could. And so the response from the director was, we are not going to accept any change in state plan as long as they will not allow foreign dollars to be used in foreign healthcare providers, while the system that is right in your land, in your own backyard, is suffering. So that was the response that, so I just wanted to confirm that that was the response that we received. So that's why it continues to be not accepted for, to have the state plan changed to cover foreign providers. Thank you.
Thank you for that clarification. And are we correct in understanding, though, that there hasn't really been a detailed analysis of, like the cost comparison of sending out patients, Medicaid beneficiaries, to non-Medicaid providers overseas versus sending them to providers here on island, or sending them to Medicaid providers in the U.S.?
I'm not aware of that.
Okay.
I don't think they have. I mean, they haven't done any analysis in regards to that.
Okay, thank you. And I think, Rep. Atzal, did you want to add to that?
I think it's the question posted by Vice Chair is critical for medical referral to be here, because they sent out these information to the various hospitals associated with our medical referral program. So the first responders, usually a lot of the cases are sensitive cases and need to be addressed instantly. So the first medical providers that would respond, that's why they end up in these locations. So, I mean, it's unfortunate they're not here this afternoon to answer that question, but that's what they have to go through.
And I think they did say that.
Yes.
Mr. Saban said something to that effect last week as well. And I think Vice Chair Staffner, you still have the floor if you wanted to continue with your question.
I will yield for now, thank you.
Okay, thank you. And Rep. Babaksa.
Thank you, Chairwoman. Welcome. Thank you. Thank you for being here. It's really, honestly, just, I have to comment on how powerful it is to see women here at the public hearing. So thank you for being here and for your testimonies. I do have a couple of questions, and of course, many of them did stem from last week's public hearing when the director was here, Director Ron Sablon. And so I will go ahead and, well, let me start with your testimonies. SAA Rosario did mention that the administration believes the referral program should be moved to CHCC. And then we heard something different from CEO Esther Muña. But in SAA's statement, she did also mention that discussions have been made and there's dialogue regarding this transition. Can you please elaborate on these meetings, these discussions? When was the last time that happened, and what kind of concerns were raised, and what kind of solutions were discussed? And so I'll go ahead and just ask SAA Rosario to begin, since
Ms. Rosario, I'm sorry, if you could please turn on your mic.
Oh, I'm sorry.
Thank you.
I know the discussions, the administration has been going back and forth since during the late Governor Enos's time. We really felt since the beginning when it was taken, when medical referral was taken, in fact, even with Medicaid, taken out of Public Law 16-51, that it has no place in the office of the governor. I mean, we don't deal with medical stuff, but at that time, because CHCC was a corporation, and Esther is here, we didn't want to put the burden of the financial liabilities to the new corporation. So therefore, that's why the late Governor Enos came up with the executive order to take over medical referral supposedly on a temporary basis while, to help it pull through financially. Someone had to look at the program, look after the program, because at the time about in the millions of dollars that the medical referral was in the red. And so not that the administration was ready to just step in and take care of those, the liability, but that it stepped in to ensure that we manage the financial part of the medical referral program. So unless, and I know Esther has, we've been trying to deal with Esther to have her move the medical referral program back to the hospital. She has then not given us an answer and refuses to take back medical referral, but it really where it should belong.
Right. So if I remember correctly, if I could just jump in here, there was some discussion that began during the Fiscal Response Summit last May or April or May 2020, and then there was this medical referral report that CHCC prepared, collected data, and some serious thinking that went into what this transition would look like. But then when it came down to the actual passage of the budget, there was no funding for the transition, and it was the status quo that remained, right? Yes. So the last time there really was this dialogue, just to go to Rep. Baba's question, was sometime last year before the budget. Is that correct?
I remember the last time we had this dialogue was, I know before even Typhoon Yutu hit in 2018. I'm sorry I don't have that information or any document at this point in time that in order for me to provide that at this hearing, but I can get back to you and find out if we have any reports, anything that was documented back then. So when Yutu hit, we kind of, just drop the subject for the time being. And then, of course, the pandemic hit again. There were just so many things that had happened since Typhoon Yutu, so we were not able to go back and revisit the dialogue between the administration and CHCC. But I will get back to you once I get those information, the last documented dialogue with CHCC.
But just to clarify something you said earlier, it's the administration's position that the transfer to the governor's office was always meant to be temporary.
Yes, that's my understanding.
Until CHCC could.
So we can eventually
strengthen its financial position. Okay.
Yes.
Rep. Batsa, you still have the floor.
Thank you, Chairwoman. CEO, may you please elaborate on, just in your view, if that was the last time, any discussion or dialogue happened, what concerns did you raise, and if you could clarify if that really was the last time dialogue happened, was at the economic summit?
So yeah, there was, discussions here and there about the expenditures.
Were they formal discussions, or are these just like fly-by meetings, like, hey, take it on, and you're like, no, thank you. Or did you have a serious, or did you have a serious meeting, meeting prepared with data, discussion, possible outcomes, possible solutions? Was it that kind of meeting?
No. Okay. So there was more, other agenda, other things on the agenda, and the expenditures of CHC. The medical program continues to be a topic, right? So, and if, I've always expressed that, we're working on some things. We're providing oncology care. We're providing, we're bringing a radiologist. Talks of bringing an MRI seems to be the biggest cost of the expenses for medical referral. But yeah,
Okay.
the answer
So
was
clarified.
yeah.
Thank you.
Yeah.
SAA Rosario, just to clarify your role in the medical referral program, because we did, again, have Director Ron Sablan here last week, and he stated and shared with us how much of his authority has really been stripped, even as recent as a couple of months ago, when it comes to awarding contracts, when it comes to hiring those responsible for the medical referral program and the services offered at our satellite offices. Is that the role that you play? Do you review the contracts? Do you award contracts? Do you hire? Is that your role?
In reference to your first question, Rep. Babalta, no, I don't award contracts. I inherited. I sign invoices for payments for contracts that have already been executed. So since I took over.
When was that? When did you take over?
May of 2019. May of 2019. So so when I took over, I was not at the time approving payments. It was somebody else's role, and I took over that person's role when that person left the governor's office.
What position did that person hold? Was it the former SAA or was it another title?
The former chief of staff.
So the chief of staff was the one responsible for.
Yes.
And who was that at the time?
Congressman Angel de Mapon.
Okay, so, okay. I'm just trying to really help us understand the structure of medical referral, because I believe that so much of the issues stem from the structure that we have in place, or lack of structure, right? And so last week, Director Ron Sablan did share that it was the SAA who had a lot of the decision-making authority that he no longer has. So since 2019, you took over, and at that time, a chief of staff was, responsible for awarding contracts or
Yes.
or payments made, vendor
Yes.
contracts. Okay. And now, does the chief of staff position still involve him or herself in that decision making, or is it now strictly you?
Now it's strictly me signing off on invoices starting in January of this year. Just signing off invoices for payments for contracts that have already been executed and obligated.
Okay. And your position as a cabinet member, correct, is SAA. Can you just briefly describe what that role entails?
Basically, the Special Assistant for Administration is responsible for the administrative function of the Office of the Governor and the entire executive branch departments. So, and basically the role also is to make sure that I report to the governor and lieutenant governor in terms of all activities under the administration.
Okay, so do you also entertain requests for appeals? The discussion of appeals came up in the number of hearings that we've already had, and patients themselves are saying that if their request has been denied at the medical referral board level, they take it to the office of the governor. And does that go through you?
No, absolutely not. I
So
don't get involved in any medical appeals or denials for medical referral.
Okay. And since you have been in your position, were any contracts awarded?
No.
So all vendors.
At this point, no.
Yeah. So all vendors were existing vendors from
Yes.
before 2019, correct?
No.
Before you took over?
Before I took over, yes.
Okay, so no other contracts were
No.
awarded, any other positions filled for medical referral? Hires, any hires?
None other than the normal medical referral assistants. As a matter of fact, there's 3 contracts that we just cleared. Medical referral assistants for the Saipan office, Saipan Medical Referral Office.
And do you work with Director Ron Sablan when
Yes.
hiring, when reviewing, the qualifications of these applicants?
Yes, absolutely. Yes.
Okay. Okay, thank you. Thank you for just providing more insight for me. And my next question is for Acting Director Torres. Thank you so much for your opening statement. As you are now serving as Acting Director, but what is your role at the Department of Finance?
My role is, I'm the Director for Administrative Services.
Director for Administrative Services. Do you review contracts that come in related to medical referral at all, or?
No, I don't.
You don't do any contract reviews?
No, I don't. The reviews are done with financial services. They're the ones that make sure this contract has a contract number, how much money it's supposed to be, and
right, and there's funding for the contract.
And then I receive it as a document for the secretary's signature.
Okay, got it.
Not really reviewing it for.
Got it. Okay, and who does the review of the contract?
Financial services, it would be either Bernie Palacios, she's the director for financial services, or one of her staff.
Okay. And last week, Director Sablan mentioned some contracts may have a conflict of interest. Specifically, the contract that the Secretary of Finance has at the San Diego satellite office. It may not be in his name, but it may be in his wife's name or an immediate relative. Is that something that you are aware of? Is that something that the Department of Finance, that the Financial Services Review Specialist looks into when awarding a contract, a conflict of interest that may exist?
Congressman, yes, it was bidded out and it went through the proper process. Even though it had his wife's name on it, but it went through, and the Director of Medical Referral was part of the, I guess, well, he was the only one that bid it. So he was part of the either negotiations or the signing of the contract.
And it was reviewed by legal counsel, correct?
Yes, sir. Sorry, ma'am.
Okay, thank you for that clarification. And are you aware of any favoritism in the Department of Finance when it comes to releasing vendor payments? We have been informed that some vendors get paid before others. Some haven't been paid for months, while others are paid. Those specifically, just related or having a connected.
I don't have the information for you because that comes out from the Treasury Office.
Okay. Do you have a list of unpaid vendors?
Not with me, but yes, we do have unpaid vendors.
You do have unpaid vendors related to the medical referral program?
Oh,
yes?
I'm not sure. No, I'm not sure.
Okay. Thank you very much. Madam Chairwoman, I just have one more question, and this is for Ms. Director Helen Sablan. In regards to your testimony, just informing us, thank you so much for your testimony as well, for informing us of the Inter-Island Medical Referral being covered. The Medicaid program is able to reimburse Inter-Island Medical Referral because we use CHCC's public expenditues. Is that correct?
Public expenditure, that is correct.
And
at
so that's
this
through
point in
CHCC.
time, I think they're still reviewing it. It's not being done yet, but they're working on it. But we still need to submit it to our grantor agency for their review and approval. but it's there, it's an allowable cost as long as we submitted it and have them review and approve.
Is this the reason why patients, if they are looking to be reimbursed through the Medicaid program, they must go through CHCC? Our clinics, does this impact patients that may be referred from providers at clinics on our neighboring islands?
Yeah, but not necessarily just CHCC. They could come here or be referred here, and they could go to the private clinics that are Medicaid providers.
Okay.
So what I'm referring to is the transportation cost, where we can pay it out under the certified public expenditures.
I see. Yeah, okay. Thank you very much for your answers.
You're welcome.
All of you, Director Sablan, CEO Munia, SAA Rosario, Acting Director Torres, thank you for being here. Thank you, Madam Chair. I yield.
Thank you, Representative Abata. I do have a few questions for each of our panelists. I guess starting with Ms. Munia. On the Inter-Island Referral Program, who reviews Inter-Island Referral requests?
So the inter-island request would go to the caseworker or the staff from the different health centers, and then forwarded to the chief medical officer or the deputy chief medical officer, who basically makes that recommendation as well and reviews it and then processes for approval.
Okay, so the medical referral board is not involved at all in inter-island referrals?
No.
Okay, and under what circumstances would an inter-island referral request from a provider be denied by CHC?
Well, it could be, for example, there's a visit from our provider that's going to these islands. That could be a denial, so especially if the urgency of the care, you're looking at the acuity of the care, and you decide whether or not this can wait or this can be something that can be done by a provider that will be traveling there in a week or a day or so. That could be one. There could be, the care could be something that can be done on the island as well. That could be the reason for that. There's some requests that basically want to go straight to another provider, and that provider is available at CHCC, so that could be a denial as well.
And is there an appeals process for inter-island referral denials?
Not really, no. I mean, you could appeal it with the caseworker, but what I'm saying is that it's not, usually that it can be reviewed by the medical officer again and consider, and you can come to me as well. But
there isn't a formal process for appealing a denial?
Well, there is. I'm sorry, correction. There is someone that can process it and say there needs to be a review of it. So there is that appeal. So there is a request for a further review, further consideration.
Okay. Okay, so if they're denied by the chief medical officer, then a patient or the requesting provider can request another review, but it would be from the same people who reviewed it in the first place?
It could be from me.
It could go to you.
Yes.
Okay. And is that in your internal procedures? There are SOPs, right, that CHCC has adopted for inter-island referral?
Yes, sorry. There's so many procedures we've been looking at.
Okay.
It's a new procedure.
It is, right.
Yes, yeah.
And so on that note, the new procedures for non-emergency medical referral, inter-island medical referral, they were a subject of discussion during the hearings on Tinian and Rhoda. And, but it was also said by a couple of the witnesses that the policies aren't being fully implemented at this time because of COVID. So to what extent are they being implemented, and when do you anticipate that they will come to full implementation?
I believe the only one that's not implemented is the copay.
The copay.
Copay, which is usually a co-share of the expenses. And yeah.
Okay. And when do you expect the copay portion to be implemented?
I cannot, determine that. I mean, we'd have to wait until this pandemic ends, basically.
Okay. Was there any public comment period for the new protocols?
No, this is our internal policy.
Okay. Will you accept public comments?
Let me just go back to the reason for the policy changes. It is unfunded, it is coming from, so where is money coming from? And obviously having someone to co-share it is something that we had to consider to make it continue to run. If there's no money source, there's a source of funding, where do we get it? There's $87,000, for example, that was appropriated to CHEC in the past year. That will probably even treat one patient, I mean, those are things that we had to consider in creating this policy. It's no money, we need to find a way to make it happen.
To what extent, though, could you avail of Medicaid reimbursements for inter-island referral?
So there is a matching, as she said, which is something that, again, has to be funded.
So it's the match for, because most of the inter-island referral patients be Medicaid patients?
No, not all of them, but yeah, most of them. Yeah, you're right.
Okay.
Correct. But
Okay.
it requires funding from CHEC.
Okay. So one of the issues that came up again with respect to inter-island referral had to do with the disparities that arise with respect to the copay once it is implemented, but the disparities that would arise for patients who aren't lucky enough to get free lodging covered by the municipalities at the Rotary Guest House, right? And then if they do have to come to Saipan for care that they urgently need, they would have to fork out of their own pockets this copay that is not based on income, it sounds like, right? So some patients who are just lucky enough to get in first, to get that free seat, free lodging at the guest house, they'll have that benefit, but others who happen to come in after them, regardless of income, would have to bear the burden of this new copay, right? So is that something that the CHCC has considered at all? Just to ensure, I guess, more equitable implementation of the copay requirement?
So we haven't implemented it. In regards to housing, I mean, again, that is coming from the bucket of CHCC.
Right.
It's, I mean, when we get appropriation, we got appropriations that we never got. So there's a lot of, promises here and there that we're going to pay for this, and this is a tough decision that we have to make, because otherwise, we have to think of this as the whole. How do we make a program run? And if we can't run it, then do we shut it down? It has to be. You have to put some measures there to make it sustainable, and so that's what we did.
Okay. Yeah, I understand what you're saying. It's you're in a difficult position as well. My last question on inter-island referral is, are there currently any written agreements between CHCC and the Community Health Center on Tinian to accept patient referrals from these health centers, or if another community health center opens on Rota, for example? Is there any written agreement, any protocol for handling patients who need urgent or emergency care at the CHCC health centers or need to be referred to Saipan?
We have reached out to them, and we actually, it is required by their grant that they have to have an agreement. To this day, we have not had an agreement. So we have reached out to them, we've given them a draft.
There is a draft, okay.
We've given them a draft. And it is our understanding that they do not want to sign the agreement.
Okay. I guess that could be a subject for future discussion. Okay, and then finally, on the Medical Referral Board, the Off-Island Referral Board, are they appointed by you?
Mm-hmm.
And how are they selected?
It is selected based on this is again, it is based on the different specialties. So we have internal medicine, pediatric surgery, try to accommodate that as much as we can. We also have with the limited providers that we have to keep in mind also that we have a responsibility to have medical providers serve in many, many committees within the hospital. So to try to get them to get participation, CHCC is obligated to staff the committees within the hospital. In regards to the medical referral committee, that is the regulation of the medical referral, not ours. So we make recommendations, we make the appointment of these individuals to serve in this committee. And it's based on availability, who can serve it.
Okay. And going back to the appeals question, are you ever asked to review appeals of medical referral board denials?
It is not my role to make appeals, to process appeals.
Thank you. Colleagues, did anyone have any further questions for CEO? Okay. Okay, maybe we could move on to the next panelist. Thank you, Ms. Muñoz. I do have other questions for Ms. Torres. So could you just briefly clarify what role the Department of Finance then plays in the medical referral program?
Our role is really just processing the payments.
Just processing payments?
Yeah.
Okay.
We receive the certified invoices by the medical referral staff, and it just runs through the system for payments.
Okay. And have you had a chance to review CHCC's report on the medical referral program from October 2020?
I'm sorry, Congressman. No.
That's okay. I can send you a copy. But it does reference some pretty major disparities in the expense records between the Department of Finance and the medical referral program. The differences have ranged from $450,000 in 2011 to $5.5 million in 2019. Do you have any comments on what might account for such large discrepancies?
Maybe after I review that report, I can get back to you, but as of right now, I don't have any comments.
Thank you. And could you comment on the challenges of containing costs for the medical referral program? So how is it that this program can so consistently go far beyond legislative appropriation? Like what happens once they reach the budgeted amount?
I'm sorry, Congresswoman, maybe that I could bring that question to David and he can answer it a lot better for you. I cannot answer that.
Okay. May I ask when the secretary will be returning?
Secretary will be back on Monday.
Okay. So who at the Department of Finance then monitors medical referral expenditures and can say, okay, now they've reached their limit, now we need money to be reprogrammed?
That's the Secretary of Finance.
He himself?
Yes.
Okay. Okay, thank you. Rep. Abalta, did you have questions for Ms. Torres or for the next panelist? Ms. Rosario? Okay. Why don't you go ahead? I also have questions for you.
Thank you, Chairwoman. SAA Rosario, you did state that you have not awarded any new contracts to vendors, but have you renewed? Have you approved any renewal of contracts for our vendors?
No. Like I said, my only involvement in the medical referral at this point is signing off on invoice authorizing payment to vendors for contracts that have already been executed and obligated.
Right.
But
how long
have
are these contracts
not-
for? I'm thinking since 2019, a few of these contracts should have expired by now, right? Or have requested for an extension or a renewal.
Honestly, I'll get back to you on that one. I have not looked at the contract,
Okay.
but I can give you that
Okay.
information. Yes.
Do you know how many vendors we have? How many invoices or payments do you authorize payments for? How many vendors do we have committed to the medical referral program?
At this point, we have three vendors.
Can you state what
Uh,
three vendors?
The Codo, KODO,
Uh-huh.
Town Place, and Town Place Residence, and Mariana's Connection.
And are these all transportation service providers?
And yes, transportation, lodging as well.
So Kodo,
KODO, KODO.
located where?
San Diego, but? LA, I think this is LA, yes,
And
LA.
it is lodging?
Lodging and, yes, both transportation, lodging, and
And,
logistics.
okay. And Town Place is located where?
San Diego,
And that is lodging and transportation as well?
yes, the same.
And,
And Mariana's Connection as well, San Diego.
and are these all hotels?
Yes. Basically, yes, they're hotels,
Mariana's Connection is a hotel?
right? Mariana's Connection?
No, really.
Oh, sorry, I take that back. Logistics only, I'm sorry.
Okay.
So Mariana's Connection is only for logistics. And these other three are all hotels.
How about Pagoda?
I don't have Pagoda. I have not signed off on any Pagoda for vendor payment or for payments or invoices.
Okay, that's interesting. I used to live in Hawaii
Oh, yes.
7, 8 years, and I'm, well aware. I visited family members at the Pagoda Hotel.
Uh-huh.
I thought that we had a contract with the Pagoda Hotel to block out rooms.
We normally do, right? We do have blocked rooms, and we've dealt with Pagoda for so many
Yeah.
years, and I think it's still in place. I have not
you
seen
don't.
a new contract for Pagoda. I have not signed anything for Pagoda.
Have you, acting director, seen any? Okay, Chairwoman, do you have any clarification on the Pagoda Hotel agreement?
My understanding was that the medical referral office and the Hawaii office does still fall under medical referral, right? It's not a contractor, those are staff. Am I correct?
They do have staff in Honolulu, yes.
Right. Yeah, but I think
I see.
I think
I
that
get
we are illuminating a problem, right? Where
Right.
there's just not much clarity in the structure and the organizational structure.
Right, and I kind of get it if the Honolulu satellite office will take care of payments for that when allocated funding maybe to those. Is that how the payment works? Funding is allocated to the satellite offices and then they take care of paying vendors in their area?
I believe so.
Oh, okay.
Bert, see Joe before.
I know they have an Impress Fund account.
Impress fund?
Yes.
Can you elaborate what that means?
Hawaii and Guam have an Impress Fund account, so what finance would do is get all these invoices of maybe Pagoda. I didn't look, but for example, their rental agreement or whatever is being charged to this Impress Fund account, and the cinema treasurer will, when other documents are entered and whatever on the system, she reimburses that Impress Fund.
And is there a limitation on this Impress fund?
Yes, I think it's, if I'm not mistaken, 36,000 to 50,000.
A year?
I think a month.
Okay.
But, so we can't exceed that, is what I'm saying.
Right.
That's the
Right.
max, yeah.
Have we reached limitation on that?
Um,
At this, or just for
I'm
this?
sorry, I need to get back to you with that answer.
Okay, thank you very much for that. SAA Rosario, since you only shared the 3 vendors, do we receive any critical feedback from our vendors? Do they communicate with you or anyone in the administration regarding their services, regarding interactions with patients, regarding support that they may need or understanding of our cultural practices, etc.?
No, sorry. No, I have not received any complaints whatsoever, or people or patients or escorts being unsatisfied with the services they provide. I have not heard any from these places.
So I'm going to just read a message that I received from a patient, and this is in 2019. I will send you pics of the hotel and share the problems that we face with this hotel, such as a curfew that is implemented, and now everyone is affected. The kitchen is locked at 9 p.m., so nobody has access to it. Kitchen is dirty after renovation. It's dusty and hot. And can't even turn on the air conditioning because of the mildew. The kitchen is smaller because of the new office being built, which has taken up more space. Normally I don't complain, but now that I see for myself what other patients are complaining about, I understand. The room is infested with small roaches. Bed sheet changed once a week, and all sorts of issues here. This is from a patient who traveled for major surgery, and receiving this message really broke my heart, because it's enough that you're going through something so tragic and so stressful and frustrating for your family and for yourself, but to live in this environment during that time was very concerning to me, especially given the fact that the medical referral program goes over budget year after year. Are you involved in the budget process at all?
For the medical referral, no. Well, since last year, when we wrote it up, well, usually medical referral, Mary Takai then last year, and what's his name, Ron Taisakan, we would communicate, provide me a copy of the budget, and we would go over it, and basically it's the same budget that they always do every year or submit every year. But yes, and I'm in line, the concern that you just put out about patients complaining about how unsatisfied they are with some of the living arrangements, or lodging. That's something that really should be lodged with the medical referral and then brought to our attention. If we can, if the administration can step in and assist, but I have not received any complaint to that nature. So, if you can share that with us, and then maybe we can do something to assist this patient. But like I said, we have not received any, and it has not been brought to my attention to assist, not necessarily to decide, but to assist in any way we can. Yes.
Right. It just does shed light on the lack of communication, the lack of feedback, the lack of coordination that really is happening in the medical referral program, and how it's ultimately our patients who suffer, when they're already suffering. And so I really appreciate your answers and your feedback. I know that this committee really is taking into serious consideration on how we can address these issues and make our recommendations to the medical referral services director, the administration, and the hospital, as well as the Medicaid office. And so thank you again for being here. I yield.
Thank you, Representative Bonds. I have a few follow-up questions for SAA Rosario. I'm really just trying to understand your role in the medical referral program. Because you said at this point you're strictly just signing off on invoices for contracts that were already executed before you came in.
Yes.
And those contracts were negotiated and executed by the chief of staff at the time, Angel Delaplante. correct? And at this time, you're only, did I hear you right? You're only signing off on invoices for those 3 vendors?
No, starting in January, when then Chief Demapon left the office in
Beginning of
January of
January.
this year.
Okay, but just for those 3 vendors, those are the invoices that
I'm
you're,
sorry, I think it's supposed to be for the Town Suite, Town Place, Codo, and Mariana's Connection.
so that's
Town
3.
Suite. Residence Inn, I'm sorry.
Oh, residents in.
Yeah,
okay.
residents in sold, I guess, the city of San Diego, whatever,
Mhm.
sold the building to the city of San Diego, so we had to move to Town Place.
Okay, so Town Place, residents in, so these are all in the States, right?
Yes.
And do you have any oversight on the off-island foreign offices, or those services, those contracts in the Philippines, in Taiwan, Korea?
No, I don't. I know that the C's employment contract was not renewed, so therefore we don't have any overseas or foreign countries contract for the medical referral.
Okay, and then you mentioned that you do sign off on employment contracts, and that's in consultation with the medical referral director.
Yeah, not sign off, but working together with the medical referral director and the staff in reviewing those applications.
But who
But
actually
not sign off.
supervises these staff? Because Mr. Sablan said that there are some staff working in the off-island offices that don't report to him. So do they report to you?
Yes, but this is why we're saying, you know, honestly, Chair Sablan, the medical referral needs to be streamlined. Right now, it's like there's honestly two types of employment at the medical referral office: civil service and contracts, accepted service. Most of them are accepted service, and the reason for that is when it fell on or it was brought to the office of the governor, but unnecessarily they should be in civil service, should not be in accepted service. While these employees in Guam Medical Referral do not necessarily report directly to me, they still report to Ron Sablan, but Ron and I would communicate regarding issues they have. That's when I step in and I assist.
So if there are
But-
complaints in the off-island offices, if there are complaints involving employees or grievances, do those go to you, or do they go to Mr. Sablan, or do they just stay with the officer in charge?
No, they would be submitted to me. They would come to me, and then we would work out the details. It depends on the nature of the employee's action towards patients and what have you in the office. I would discuss that with Mr. Sablan, and we both would make recommendations agreeable to both parties. And if there's a need to let go, then we let go. There's no need. And if someone, a first offense that's not severe, then naturally, what you do, we communicate, suspend, and then reinstate back the employee to employment. But
So
it's
how
not.
many-
I'm sorry.
How many medical referral staff do you oversee then?
So the one in Guam, we have I think 7 in Guam.
Okay.
And I think 8. I think we have 8 or 10 here. So basically close to 20.
And then in Hawaii?
In Hawaii, there's 5.
Okay, so they all ultimately report to you.
Yes, but this is where this is where the confusion is.
Yeah.
Honestly, I mean, yes, we temporarily took over, or the administration temporarily took over to just oversee the program financially. And the only reason why we get involved in the hiring process is because the office falls under the office of the governor, and therefore became all employees became accepted service fall under accepted service employment contract. But we do not There may be one or two we would recommend to hire, but we do not take care of the whole hiring process. And we do go through Director Ron Sablan and Ms. Ron Paisakan as well. Now, for those in Guam, we prefer to hire, and a lot of them were recommended by the medical referral personnel to hire people that are staying in Guam, because it's cheaper to just hire them rather than to hire them from here, then it would become an off-island hire, which would be costly.
Okay. And just last couple of questions in this thread. It's also our understanding that there are discrepancies in the benefits and the pay that are given to medical referral staff. So Hawaii employees can avail of housing allowance, but nobody else gets that benefit. Who makes those calls? And could you address that?
The hiring authority, which would be both, I would say medical referral and the office of the governor, but for those that are not receiving housing benefits or off-island benefits, would be the people in Honolulu. I think I know we hired most of them outside, or not hired within Honolulu. Like we hired them here and then sent them to Honolulu. For the ones in Guam, the reason why they're not receiving that benefit is because they were hired locally.
Okay. And then my final question is, why was authority over contracting and even sounds like to some extent hiring and supervision, why was that taken away from the medical referral office in the first place?
Overseeing the office, you mean?
Yeah, like oversight over these contracts, over employees, over hiring. Why not just leave that with the medical referral services office? Like why was it fractured this way between SAA and before you with chief of staff, right? Why did that happen?
Simply because the office goes under the office of the governor, and we make recommendations, but not necessarily take the authority away from Ron or from Mr. Sablan. Mr. Sablan still signs off on these contracts. There is no signature on my part on these contracts and the personnel actions. So it's Mr. Sablan, who is the hiring authority.
But you would agree that there's confusion.
There is, and it's the reason why we keep saying we want the medical referral again to go back to CHCC. That's where it rightfully belongs. That's where all the doctors are, the specialists. The governor's office does not have that, my sister, so you need to take it back.
And I see CEOs enthusiastic, welcoming of this program.
I mean, it's, I know you didn't want it, but you gotta take it.
Okay. Well, thank you, Ms. Rosario. Did anybody have any other questions for Ms. Rosario? I have a few more for the Medicaid director, and then I think we should open for public comment.
For Ms. Rosario.
Yes, Rebecca.
Ms. Rosario, thank you, ladies, for joining us this afternoon. I think that in regards to the salary discrepancies, especially in Guam, that's the biggest challenge because of the MOUs with the mayor's offices from Rota and Tinian. So obviously, some of these individuals that are living in Guam that are from Rota or Tinian are MOU'd under the mayor's office over there, and they're making a much larger salary than the actual medical referral employees. And that was one of the things that we had brought up with the mayor's office, was to take away those FTEs from them and actually put it directly under the medical referral office. But obviously the challenge was their salary is gonna drop.
No, but we did. We did. For Guam especially, we stopped the MOU. There's an issue to the MOU because and you're right, the reason why there's disparity in salaries is because our medical referral employees get, for example, are receiving, for example, $27,000 now, but the ones, the MOUs are way higher, like $30,000, $35,000. And the reason for that is because they're hired from the mayor's office and then detailed to Guam Medical Referral. But we have stopped the MOUs because that not only was the salary an issue, it was also supervision.
Absolutely.
So even if the medical referral officer in charge in Guam wants to disapprove a leave application to take time off for MOU employee from Tina Mayor's office or Rota Mayor's office, these guys would turn around and say, if they're getting denied by the officer in charge, they would snap back and say, you're not my supervisor. So that is one of the main reasons why we had to do away with the MOU and put them, if they want to get on board with medical referral, then they have to go into medical referrals FTE. If it requires a reduction in salary, then it's contract. So it's basically up to you to whether accept it or not, a lower pay.
All right, thank you. That's actually great news to know that we're gonna do away with the MOUs. I think that's one of the biggest challenges that's faced, especially Guam now.
Yes.
But I know this is probably a very unfair question to both the SAA and CHCC, but would you recommend that the medical referral office be independent away from obviously the governor's office and CHCC?
I honestly, if it truly believe that if it can be an independent agency, a semi-autonomous, an autonomous agency, I mean, I know that it has always been politicizing the office has always been a topic. And I keep saying, no matter where you put the medical referral, it will still always be, there will always be a political issue with medical referral, no matter what or how we explain that it cannot be done. So medical referral staff, and I've shared this with Ron in the past, even in Guam, we shared it like, it cannot be done. So who do they reach out to? To our elected leaders. And then, so it's no matter what, I'm not sure that if you put it as an independent agency, that there will not be any political involvement. I still believe, and honestly, it would always be a political issue.
I absolutely agree. And CHCC, I know, I like I said, this question's posted, it's very unfair to both entities, because one of the statements that the representative for the medical referral board from CHCC side actually said that they didn't want to be involved with the political process of it because it's always going to come from the top down. And one of the recommendations was to make it independent. And obviously, the administration won't be blamed for everything, right? If it's under the governor's office, if it's an independent agency. But then again, if the funding follows the transition, I'm sure CHCC will be receptive to it, provided that the funding's there.
I mean, it would always be under budgeted. So I was just sharing that earlier with our legal counsel. I said, even if you give medical referral, you budget medical referral 100 million, there's always that unanticipated expenditure. So when you send a person, an employee or a patient to Guam, for example, and it's supposedly estimated time of return is within a month, but then the last follow-up, something is detected again before this person is ready to fly out of Guam, something is discovered, and so the doctor holds back this patient for another 2 weeks. So there's that 2 weeks again you incur under, that's what I mean by unanticipated expenditure when it comes to housing. I mean, well, we all have blocked rooms, but that's the allowance, the staffing that you have to, if you have to pay overtime, you have to pay overtime. But that's why I'm sorry that I just thought I'd share that concern because it is honestly true. no matter where we put it. But if we can bring it and make it into an independent agency, that would be awesome.
Well, I think that's why now the question is very unfair, because medical referral, whether we like it or not, it's gonna be here
Yes.
today, tomorrow, and far beyond our time. And it's a moving target, where it's never gonna be $100 million to that. It might be $1,000 this year, might be $5 million next year. And obviously with COVID, the decrease of medical referral responsibilities have obviously went down. So sorry, CHCC, you were gonna say something.
Yeah, I mean.
I know, no worries,
She's
sister.
my cousin. You know, I guess, you know, what exactly do we want medical referral to be, right? I mean, if it's an off-island care, you know, CHCC, I mean, we've been talking about this so many times, and if we're going to make it work, I think there needs to be not just be independent and act alone. I think it needs to work together and try to figure out, you know, what can be referred and what can be sent off island. Maybe even change the word referral, right? Just come up with something where you are trying to bring things here, but at the same time make an arrangement, maybe with our providers. I mean, I'm looking at medical referral as an office that makes payments to providers. We don't even have a contract with those providers. It's between medical referral and the provider as a payer. And even with the travel costs, you know, how do we reduce that? So I would say that if we're going to make a change, I think the change should include on sustainability, making sure that you have the services, build on services that you can provide, and then make an arrangement between our providers. And, you know, you asked a question about appeals. If it's coming to us and you look at Public Law 1651, as she was, essays was pointing out, that it was given to CHCC with the intent to not be a liability to CHCC. But then an executive order came in and says, okay, we're going to take it away from CHCC because of the lack of funding. You know, why didn't that happen? I don't know. You know, that's something that we need to consider and think about, and how do we address moving forward. We don't want to make the decisions of someone leaving island, you know, to access care. We don't want to be the one to make sure. I mean, people in Tinian and Rota have struggled, and, you know, there was a conversation at one point where we were reporting from Tinian about, you know, dental services. For all of us here, we think of it, take it for granted, and think that's, well, what do you mean dental services? Why are we referring dental services? But it's because they don't have it there, you know. And so when we hired Dr. Sabino and hired another dentist, we had two dentists, and we make sure that they're actually providing service. And we're looking at teledentistry, you know, to try to bring those services there. It is not what people are asking for, maybe, but it is what we could provide with what funding we have. So what exactly do you want? We need to ask we already know what people want and what is missing, and let's see what we can do to help them. And we would love to be at the table to try to make it better. You know, as Savon said, that there's things that probably they could pay for. And let's see, we, you know, continue. And I you know, again, I'm hoping that you would consider what can be provided here. COVID has shown us that people would rather die than go off island and die alone, right? So how can we help them? So there's a lot of cries for help. So anyway, so in regards to being separate and being, I don't agree with it. I think you need to stick it into the system, fix it, and listening to the people's stories, I think we have an idea of what we need to do, right? So thank you.
Thank you, Rep. Atal, and thank you for both your thoughtful commentaries. I actually wanted to direct that question to the Medicaid agency. So, we've also looked to Public Law 2128 as a possible model for establishing a, an independent agency under the Office of the Governor, but that has some insulation, right, from the political forces and where the parameters are established for the types of services that could be covered. Do you have some thoughts about that? I know that implementation of Public Law 2128 is still very much in the beginning stages, but what are your thoughts about that being a model for medical referral?
I would think that would be a great idea, is to separate it and be independent, provided that, they have a financial support.
Mm-hmm. But still under the executive branch.
Correct.
And still with the CHCC physicians sitting on the medical referral board.
Yes.
Okay.
They are the expertise, so
Okay.
they should be.
Because there are
They
some
still
things
continue.
that do work, right?
Yes.
And it's just that there's a lot of disjointedness, a lot of fragmentation, confusion about who's in charge, right, and who's accountable. So if we could, and I think part of the challenge is that there really is no law. It's just regulations thrown together and policies that have been adopted and changed over the years. So a couple of questions for Ms. Sablan. I wanted to get a better understanding of the types of data that the Medicaid agency keeps with regards to inter-island as well as off-island medical referral. I know you provided some of that data, but are there challenges that you're seeing with respect to keeping accurate records of the services that are being paid for, for people going off-island for care?
Well, the challenges that we have, we're receiving the claims and that's what we base ourselves, but basically coming from the medical referral, giving us, the data, it's pretty vague.
How so?
They cannot separate how many Medicaid patients versus insured patients and non-insured or uninsured. And so and right now with the system that we don't have in place, we're working towards getting that in place. It's kind of hard to predict, what is the highest ticketed items on paying medical bills. So.
And you're referring to the Medicaid Enterprise System?
Correct.
You're getting your FTEs this week.
Okay.
We're supposed to vote on that on Friday. Okay.
Thank you.
And that is something that the special assistant last week said CHCC could also assist the medical referral program in just improving, I guess, the quality and the integrity of the data that's collected. And then I guess my last question for Ms. Sablan is regarding utilization review. This has been raised a number of times as a major gap in the medical referral program. We understand that Aetna is now providing utilization review expertise for the claims that Aetna will cover, but does Medicaid also assist with that?
Actually, no, we don't have, not even on board. We don't have any staff that do the utilization. So, as the bill comes in, we would just have to verify if it's a covered services, Medicaid recipients, and then we will pay for it.
Okay.
But we'll eventually look into that as well. But
Okay,
it
so you're not
would be great,
Yeah.
to have from the medical referral side, because they're the one that's sending out the patients, for a particular specialty care that they need. So they should actually look into that. I know that in the past in Hawaii, they used to have one, but I think she's no longer there. But for the U.S. mainland, I don't see anybody there.
Yeah, and I think under the regulations, they're required to have it. But I guess the budget has been the limitation as well. Okay, that's it for my questions. Did you have any other questions? Did any of our panelists have any closing statements to make before we open up for public comments?
Thank you for this.
I want to thank all of you as well, Ms. Sablan, Ms. Munoz, Ms. Rosario, and Ms. Torres. Thank you for your presentations today. And we do have some follow-up questions for the record. The committee will be circling back with you for those responses. Okay, thank you very much and have a good evening. And at this time, colleagues, we can open up for public comments, if any, from the gallery. Nada, did anybody sign up for comments? Okay. Well, it looks like there are no public comments. I do want to announce that the committee will continue to accept written comments after today's hearing through next week, Friday, June 4th, 2021. Is that deadline acceptable? And members of the public may email my office at rep.sablanc@cnmilg.net. You may leave if you have to. You don't have to stay for the night. You're welcome to. But I see that it's 5:50. We're just wrapping up. So we'll continue to accept comments through June 4th. And colleagues, members of the public, this concludes our 4th public hearing on the medical referral program. In terms of next steps, I would like to ask the members and our staff as well to review all the information and testimonies that we've received, determine whether additional data or testimonies are needed, and consider the problems as well as the recommendations that have been brought to this body that we may address in legislation. I do believe it is important to establish parameters for the medical referral program by law and provide some clarity and stability for medical referral. Adequate funding must also be coupled with reasonable and necessary constraints to manage costs, provide equitability and accountability, and make more resources available for improvements to healthcare services and infrastructure here on island. And I would like to open the floor for any other comments from the members at this time. Okay, I think that we have reached the end of this hearing. May I ask for a motion to adjourn?
So,
Second.
Motion has been made and seconded. All in favor of adjourning this public hearing, please say aye.
Aye.
All opposed, say nay. It is now 5:15 p.m. This hearing is now adjourned.
Thank you.
good job.
Thank you, party.